I treated this tooth number 3, upper right 6, 12 years ago, and now I'm retreating it. Stick around and find out what happened. I'm Bill Nudera, and welcome to my channel dedicated to clinical endodontic education. "12 years ago, I treated this tooth number 3, the upper right 6, and it was diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis. This predates my cone beam scan, so I had to make some judgment calls based on the two-dimensional projection imaging. I felt comfortable with how the treatment went. I found 4 canals. There were no complications. There were no issues. I used a warm vertical obturation technique, and I placed an orifice barrier and sent the patient back for the final restoration. This was my final result 12 years ago. Not bad. I was pretty happy with it. The patient returned for a 3-year follow-up and reported some symptoms from time to time in the area, but nothing significant and nothing terribly remarkable requiring any medication. At the time of the 3-year check, there were no symptoms. It was palpation negative, it was bite negative, and percussion negative, so we decided to continue observing. At 7 years, the patient returned again for another follow-up, reporting the symptoms really hadn't changed over the course of these last several years, and once in a while the symptoms would come and then they would go. We took another PA. There's nothing that shows up on the PA. I took a cone beam scan, and the scan also appeared clear. But the tooth this time was a little tender to percussion, a little tender to bite, but again, nothing remarkable. But there's no evidence of anything going on here. Again, we can't rule out fracture, and fracture is always the first thing that comes to our mind whenever we have a symptomatic case that looks good and we don't understand what's going on. It can't be ruled out, but it's not terribly evident here either. So without any significant evidence here, and since the discomfort wasn't consistent and still extremely low on the visual analog scale, we chose, again, observation. 12 years later, the patient shows up in my office for an emergency treatment with localized pain to tooth number 3, significant pain to tooth number 3. There's no signs of swelling or infection. I took a PA. There's no signs of pathology, but the tooth is severely tender to percussion and severely tender to bite. I was able to capture this cone beam scan, and now the issue is clear. There is an area of low density on the palatal side of this mesial buccal root complex. I originally treated 2 canals, so I was thinking immediately fracture, because it's following that typical pattern that fractures will follow, riding up the PDL space. And again, although fracture can't be ruled out, we still had some options here. With the information I have from the scan, it's suspected that there may be some additional anatomy that's present here in the apical third. So although I originally treated 2 canals, it's certainly possible that the canals merged mid-root and then split again in the apical area. And before I subscribe to having this tooth removed, we at least owe it to ourselves to go back in and see if I can't improve upon anything. The patient understands the risks, understands that we may not be able to do any better than we originally did, but it's certainly worth a try. So after discussing all the options, including extraction, retreatment, and surgery, we decided that selectively retreating this mesial buccal root would be the best and most conservative option moving forward. I used a single tooth isolation technique with rubber dam blockout material, and I chose to remove the majority of the original core just to make sure that there was no issues with the integrity, and it appeared clinically sound. So I moved forward as planned, and I exposed that mesial buccal root complex. We can see the original 2 canals that were treated, and we can also see that that obturation material that was placed 12 years ago looks pretty clean. In some of my prior videos, I described a technique with advanced file bending to try to get into some deep canal splits of type 4 anatomy. Well, I tried that here, and I tried for a very long time doing that, and it didn't work. So although those techniques are really great, sometimes we fall short of being able to apply those techniques all the time. And I've also mentioned in the past that it's really risky to try looking for these deep splits with ultrasonic instrumentation due to all of the damage that gets created in that process. Plan B for this case was going to be a surgical root resection. So knowing that I had that in my back pocket, I went ahead and I took that more aggressive, risky approach, and I began troughing down that mesial buccal root to try to identify some deep anatomy. It was pretty easy for me to stay on track because I was just following the original canal system that I treated 12 years ago. But I could only trough down to the level of where the canal begins to curve to the distal. I troughed down 16 millimeters, nothing. So I threw the GentleWave on there with the hopes that something would be able to present itself. And this is what I saw after the cycle. bleeding. Now, this could be a good sign or it could be a bad sign. It could be a good sign in the sense that maybe this was able to uncover or remove tissue in some really deep canal anatomy, or it could be a bad sign in the sense that I may have perfed and this may have created or actually opened up an area that I may have perforated. I wasn't certain yet what we were dealing with, but it was something. Fortunately, it was the former, and it was that deep canal split that I had been searching for. And now that I had uncovered it and visualized it, I could treat it and I could instrument it. So I followed my normal shaping protocols. I re-irrigated with positive pressure technique, and I obturated both canals with a single cone obturation technique. Here's my cone fit image, and I just saw all of that apical anatomy. And now it starts making sense why this patient was dealing with so many symptoms over the last 12 years, albeit that they were mild, but they were still present. This is the final obturation, and I was thrilled to have been able to treat this deep anatomy. But if we look at this demonstrates the significant risks that one takes when attempting to trough deeply. A fraction of a millimeter in any direction could have been disastrous. Fortunately, this one worked out. I captured this post-operative cone beam scan, and it demonstrates that deep split and that separate portal of exit feeding the lesion. Now, I just completed this case, and this patient is due back to see me in about 6 months, where I'm going to take some additional imaging to see if there's any progress that's being made. If there is no progress and the patient remains symptomatic, we do have plans to consider a root resection in order to still try to retain this tooth. But hopefully the symptoms are going to resolve and we'll get nice healing with the tissue. So stay tuned, and I'll be sure to keep you posted on future follow-ups. Well, I hope you've enjoyed this today, and I hope you subscribe to my channel so you can stay up to date on all of my new videos. I'm Bill Nudera. Thanks for watching.